go ahead and get started. Our featured presentation today is centered on effective and equitable emergency responses. And this is a photo of the Alpharetta, Georgia 911 Center. And this was part of a look at 911 as it recently turned 50 a few years ago. So it's a little bit over 50 years old. And hopefully we are taking some of what 911 has learned across those 50 years and applying it to the 988 continuum that we are talking through today. But our featured presentation will be from Tiffany Russell, who is from Pew Charitable Trust. I've had the pleasure of watching Tiffany work and speaking with her on a panel, and I just have to say she's a wealth of information. Originally from the heart of Georgia, I am going to now turn it over to Tiffany to start her featured presentation. So Tiffany, take the spotlight.
Thank you so much, Laura. And thank you for everyone for having me be able to speak today. Again, my name is Tiffany Russell, and I am the project director for Pew Charitable Trust Mental Health and Justice Project.
And you know, Tiffany, I jumped the gun here in transferring it over to you.
Sure.
Because there's so much that I want to learn and hear from you that I just wanted to jump in. So let me back up a little bit and start with the organizations that are featured here on the Crisis Jam. So you'll see the circles are counties or territories. We have participation from other countries looking to learn and share their tips, looking to get more Medicaid and finance folks involved. So again, we have about 10 offices of state Medicaid directors involved, looking to include more. So if you think that there's anyone who is involved in behavioral health, mental health crisis services, please feel free to share the JAM information with them. We would like to have their voice here and learn from each other. So let's move forward. And so this is the Crisis Jam Learning Community landing page. This is where you can go to get the Zoom link, to sign up for the newsletters. You can see past Crisis Jams. You'll notice here that Tiffany is featured there in red. So we are so excited to hear from her. And again, the website is talk.crisisnow.com. So this features information right at your fingertips. You can watch the latest video. The community has been updated so that you can go directly into the section or segment that you would like to first. So again, you can look at the state cards, the quotes, the featured presentations. This really allows you to access the content that you would prefer right away. We have the news, the trivia. So again, you can use the landing page and look at it as it was previously, or you can also dig a little deeper and kind of go directly to the content that you would like to see. So have it both ways for people. And again, that's talk.crisisnow.com. And so one of our newest segments is the Crisis Jam word cloud. This is where you can text text Crisis Now to 22333. It will populate a new window, and you can talk and you can add your response to this question. The question this week is, what's the top strength of your state's current crisis continuum? So knowing that every state has different strengths, they're facing different challenges. We want to see if there are any threads or similarities across what states view as their top strength. So this is for everyone to reply to kind of your perspective of what's going on in your state, what the strength would be from your perspective. And you can, it's easier if you just text versus opening up a new window, although you're able to do that as well if you're on two monitors, but just take out your cell phone, text, and then we will see at the end of this meeting what has been the common words used. Thank you, Paul, for putting in the link. We move to the next slide. So also as part of our kind of new segments around crisis services in the news, this article, and there's been a lot of articles that have come out recently, and I think that is a combination of state legislatures opening. There's been renewed focus now that it's 2022, and 988 will be operational in July of 2022, kind of renewed focus within the media on crisis services. So what was interesting about this article is that second sentence there, 1/3 of patients required a sitter. So someone to just sit with a patient because they had a behavioral mental health problem. And so there's been some articles and reports around people and time spent sitting with people. So again, we want to make sure that we are effectively using our emergency departments. So if we go to the next slide, and as more folks join, if you want to, update your name to include your state abbreviation or your state information, that's really helpful for other people in your area working on these issues. We're also seeing additional news reports on funding mechanisms for crisis centers and state readiness. So I know that's work that we've all been doing and paying attention to and participating in. And so now we're seeing kind of the shift in the narrative for the media and more attention coming. So we will continue to track those articles. And it's also good to see a lot of centers featured. So I know Monica Kurz from headquarters in Kansas has been interviewed, and Jennifer Battle has been interviewed. So it's really good to see centers and the great work that they are doing focused in on these articles. This is an article from Brookings, from Richard Frank and Vicki Wachino. And so Vicki will be participating in the JAM as part of a featured presentation, I believe in mid-February. And so just talking through some of the sustainable or how we can move to a more sustainable continuum. So we'll keep going. And our quote of the week comes from Dr. John Franklin Sierra, who will be also a part of the featured presentation in February 23rd. The quote is, "All models are wrong, but some are useful." So I don't know if you are on the line, Dr. Sierra, but if you want to provide some context for your quote, I will open the floor to you. I think it is a very interesting quote. I'm not seeing him in the chat here, but I do think it's an interesting quote. I think as we are and states are evaluating 988 and connecting their crisis continuum, it's important to note that some of these models are useful, but we're probably all doing it a little wrong. So nothing wrong with taking the data, learning, and applying it. Let's go to the next slide. Okay, so now we have Tiffany's featured presentation.
Thanks again, Laura. Let's go to the next slide since I've already done my introduction. So to get started, in December of 2019, the Pew Board of Directors approved a new project that was really focused on targeting the reduction of people with mental illnesses in jails. And we were given two really main objectives in this strategy. The first was to develop some policies or a policy framework that states could adopt to really help avoid the use of jails, interactions with law enforcement, or emergency rooms as the default response for individuals that were experiencing a mental health or substance use emergency. We were also tasked with building partnerships with Texas and other states to really inform and establish a technical assistance model that could help achieve those policies that we outlined, increase funding for new programs, and to also implement evidence-based, promising practices or emerging practices more locally. Next slide, please. So given that Pew was new to the field, we really built our strategy on the development and resources that were already available. Those resources included Samsa's Crisis Services Toolkit, the launch of the Crisis Now platform, the guidebook to reimagining crisis response, as well as other initiatives like the Stepping Up initiative. So given this evolving field that was happening before us, we determined that the most strategic approach for Pew would be to look at the initial impact or the front door of this issue. And that was looking at 911 calls that were really involving individuals with behavioral health emergencies. And so during the first 2 years of our work, we really wanted to make some significant progress in identifying promising approaches, really thinking about our vision for state and local success, and then really trying to map ways to help states really take some meaningful action. Next slide. So we started with a literature review, and what the research suggested is that local traditional, non-traditional law enforcement responses got better results, and that there were certain types of crisis services that reduced the instances of self-harm, suicide, and overdose. We also found that better approaches to emergency calls could lead to fewer arrests and better access to care. Next slide. So we had a few questions that we felt that were still quite unanswered. So what elements of non-traditional law enforcement responses are essential to really realizing better approaches or better outcomes? What improvements are most likely to reduce racial disparities in arrests, hospitalizations, and connections to community-based services was still a question we felt was really unanswered. What approaches are most effective to help people access sustained community-based services after crisis was also something we wanted to investigate and look more into. Next slide. And so through this investigation, we really started talking to more local jurisdictions and other states around what are some of the challenges that they're facing. Mainly a lot of the communities that we talked to showed that, effectively being able to respond was very limited to them because of issues of due to limited funding, not really basing their local interventions on evidence or data. They were really just trying to put out the fire, just trying to respond to the challenge. And they also found that some of these local jurisdictions were working very independently and in a silo. And so the state was not able actually to realize the impact of potential of these interventions because they were very locally focused. Funding was very insufficient to allow for those programs to operate at scale. Local governments were struggling to really ensure the fidelity of those models and really to measure the results of those local interventions as well. Limited funding often led to the programs really only making it to a pilot stage as well. Next slide. So the first thing we wanted to do is when we were looking at emergency response was really trying to answer the question is how can we add to the growing knowledge base? Next slide. So what we did is we partnered with the NENA Association or the 911 Association, as well as the Safety and Justice Challenge sites from MacArthur. And what we did was we put together a questionnaire that assesses the capacity of local call centers, local 911 call centers, and how they deal with behavioral health crisis calls. So as we began working in this particular issue area, we noticed that no one was really doing the research on how the call centers were managing these emergencies to include how calls are assessed, what are their dispatch options, how the data on calls and outcomes is collected and shared. Those unknowns were fueled by this disjointed nature of the system. And we know that there are more than 5,000 separate 911 call centers, and they each have their own standards for training those call takers and dispatchers. They have their own standards for call handling and dispatch protocols, as well as data management and reporting systems. So we really wanted to make sure we had a better understanding of how those behavioral health calls were currently being handled by 911. Here are a few of the key takeaways that we learned during this process. Few 911 call centers have staff with behavioral health crisis training to inform how they navigate 911 calls and dispatch responses. So when we talked to the call centers, we found that a lot of them were not properly trained in how to, one, identify that this is a behavioral health emergency call, and also how to de-escalate those calls on the line. The second key takeaway we found was that respondents indicated that they had very limited options to dispatch specialized responses to crisis calls. Many of our call centers that we spoke with only had access to limited access to CIT trained officers or law enforcement officers. They did not have access to mobile crisis teams. They did not have access to in-house behavioral health clinicians that could help to triage and assess calls as they came in. They also didn't have the option for telehealth behavioral health clinicians, due again to some of those challenges that I mentioned earlier around limited funding, and as well as limited access regarding the workforce for behavioral health services. Respondents also indicated that their 911 call centers and service area had very limited specialized resources to address mental health and substance use related emergencies at all, meaning they were in a rural community that had very limited access to behavioral health services overall. And so not just for your emergency responses, but just overall. We also found that most respondents in our questionnaire, they do record those calls related to mental health and substance use emergencies in their electronic data management system, but only a few reported those statistics either internally or publicly. And when we were talking to these 233 call centers that we sent this result out to, we had about 37 agencies or 37 states to respond to this survey. So it is definitely not to be considered nationally representative. However, the key insights that we did get to emerge from this analysis really provided this very rare look into behavioral health crisis system services for 911 call centers. And those communities were diverse across 27 states in the United States. And they represented 16 rural call centers, 15 urban clusters, and then 6 urbanized service areas. I did mention that we also surveyed safety and justice challenge sites. However, because of the disparity in the results that we received, we did separate the results of the safety and justice challenge sites from the report that was released on October 26th. So coming in February of 2022, we will release the analysis of that report that really showed that we had 16 call centers in safety and justice challenge sites that responded to our questionnaire. And it really emphasized this use of data as part of its mission to reimagine the use of jails. The safety and justice challenge sites, again, outperformed all of the other survey cohorts, mainly with higher rates of collecting 911 behavioral health crisis data. They also had higher rates of updating their call information, recording outcomes, and also higher rates of reporting their data. And again, that report will be out in February of 2022. Next slide. So related to the report that was released in October, we also did a virtual webinar with the panelists that are listed on this slide, just to really dig a little bit deeper in the issues that we pulled out from this resource report. That information is still available online, and we can provide the link to that webinar if you are still interested in learning more about the report and listening to what the panelists had to say. Next slide. So we also wanted to look at the readiness of states being prepared for 988 implementation. We know that it was coming in July of 2022, and we really wanted to, as we were thinking about what's happening at the local 911 call centers, also really wanting to examine how do these 988 call centers coordinate, interoperate with 911 emergency services as well. And so we partnered up with the Technical Assistance Collaborative to develop this state framework for how to plan and implement 988. We realized very quickly that 988 is providing a really significant opportunity to make accessing mental health professionals in emergencies easier. And while it's creating this national strategy to improve access to care, there are still some strategies that we need to really develop and think through to really meet the local need. And so this particular framework provides some really unique opportunities to help local jurisdictions along with the state to think through how they can successfully prepare for 988 implementation. And so you can see that in this particular report, there will be things that connect to how to establish and commit to a systems level planning process, how to identify and address key considerations in 988 design, identifying and addressing coordination between 988 and 911, which we definitely think was really important and something we made sure that was covered in this particular framework. Really wanting to think about developing sustainable financing mechanisms to pay for 988, because we know that that is front of mind for a lot of states. Identifying and addressing potential implementation and transition issues. Of course, this is something that is very new. It's new to all of us. And we wanted to make sure that there were some ideas and strategies out there that would try to address issues that came up during transition and implementation. We also have strategies that monitor performance and troubleshoot problems, also ensuring connections and access to upstream services, and also how can states and local jurisdictions really develop marketing and communication strategies to really be able to sufficiently talk about 988 implementation. Next slide, please. So the next question we wanted to answer is, what can we learn from working in pilot states? As I mentioned early on, we were piloting in Texas, and we also in that process brought in the state of Ohio. So let's talk a little bit about what we learned in those states. Next slide. So why the states of Texas and Ohio? Well, we found that state policymakers were already making new investments. Philanthropic organizations were already prioritizing the issue of crisis response inside those states. There were already local efforts already underway, as well as very sophisticated backbone organizations or intermediaries that really were able to provide the state with advocacy and technical assistance. Next slide. So what did we accomplish? Well, in the state of Texas, we were able to scale a multidisciplinary response team model that consists of a paramedic, a mental health clinician, and a CIT trained police officer that's dispatched through the 911 call centers. And this pilot started in Dallas, Texas, and we're now seeing about 4 other counties in Texas that will be able to now implement this new MDRT model. The state also introduced and adopted new policies that created more access to crisis and behavioral health services. A lot of those efforts started before Pew's engagement, but they really did focus in on providing more access to emergency crisis response services as well. In Ohio, we are currently in the process of developing a pilot model for how 911 call centers interoperate with 988 services currently coming online. That development will also include call standards, protocol, financing mechanisms for how to make sure that 911 and 988 are responding and responsive to each other. The state of Ohio is also, through our work with PEGS Foundation, is developing a statewide collective impact model that is reducing the use of jails and emergency rooms for crisis response as well. And I also want to mention that in the state of Texas, our intermediary or backbone organization is Meadows Mental Health Policy Institute. Next slide. So very quickly, I just want to touch on what are some of the things that we still need to achieve nationally for more sustained system-wide change. Next slide, sorry. We want to really focus on some missing pieces that we think are still existing, and knowing that we cannot cover all of this on our own as Pew. And so we really wanted to make sure that there is still some information available, and there are still some missing pieces around financing, metrics and data, technology and innovation, community engagement, very limited access to behavioral health workforce, but very main specifically focused on racial equity. Next slide. And so what we did was Pew is starting or wanted to be one of the founding members of a national funder collaborative with a goal to really focus on finding and maximizing goal alignment among other philanthropic organizations to try and launch a coordinated, multifaceted investment strategy for sustained local success. And I just added that fire truck for a little razzle dazzle to my presentation. So please, I apologize for the noise. Next slide, please. So as I end this presentation, just wanting to share with you the goals that we're really focused on for the next 3 years worth of work. We really do want to focus on continuing to add to our knowledge base. We want to provide a detailed baseline that really establishes the state of the field, the benchmarks that could be used to really establish what progress looks like, and evaluating what actually works. We want to continue working with individual states on progress, so we want to complete that work in Texas. We really want to get this model established, as well as developing a TA plan for Ohio, so that we can scale this to more states outside of Ohio, and then also really identifying additional state targets that we can work with on these particular efforts. And then again, we want to launch this multi-year effort where we're working with a team of philanthropic organizations, again, to just really have a more sustained strategy for success of improving effective and equitable responses to crisis services. Thank you so much.
Great, thank you, Tiffany. That was an amazing presentation. I am furiously taking notes. I do want to acknowledge some questions in the chat before we go to our roundtable. Can you provide information on the counties in Ohio that you're working with and where people can go for more information? I know some of the reports are linked in the chat already, but where would you recommend people go if they have additional questions on the outcomes of those pilots?
Definitely would prefer to have people go to the pewtrust.org website and look for the Mental Health and Justice Partnerships projects. All of the materials that I spoke about earlier are linked as resources on that particular page. We do have more information coming out around this pilot work in the state of Ohio. We are still working with FEX Foundation in identifying and establishing those counties. And so we have not directly selected which counties we're going to work with or readily publicly wanting to talk about what those counties are, because we're still in the process of establishing what that work is going to look like. But what we will do is provide resources as soon as we are ready to announce the development of that pilot model, as well as the states that will be initiating that pilot model.
Okay, great. Well, more to come on that, and we are all eagerly looking forward to that report and information coming out. I'm going to bring Jennifer Battle from the Harris Center, which is a Lifeline Center, as well as Dwight Holton from Lines for Life, which is also a Lifeline Center, into the discussion. Hi, Jennifer and Dwight. If you were here, we're going to pin you up there. Just give me some feedback on what you heard from Tiffany's presentation, any kind of areas you want to highlight, any concerns?
Well, first off, I'm really excited to hear about the work Tiffany is doing. It sounds like she's partnered with some of our Texas centers, which is great. I'm in Houston, so I'm looking forward to hearing a little bit more about what they're doing across the rest of the state. We've had a 911 collaborative in place through our mental health authority for almost 6 years now, and it's been very, very effective. And I absolutely agree with the research findings that Tiffany shared. When we went into our 911 center, they did not, even though our crisis line has been available for almost 20 years in the community, there was still sort of this hesitancy for 911 to work directly with our crisis center as far as reach out and ask for support with calls or what have you. So being able to embed mental health professionals inside of the call center has been very impactful. The other thing I think was really key, the part about 911 dispatchers and 911 team members being able to identify a mental health concern is such a key piece. One of the things that we do here, and I know our colleagues in Austin that she mentioned do, or Dallas do, is also talking about identifying those calls up front so they can be coded differently as a mental health specific call code, because that really allows the responders, whether it be a behavioral health responder such as ourselves or responders in the field, to recognize that there are other options that we could bring to bear. Our center has something very similar to what Tiffany mentioned, the multidisciplinary team. We have a mobile crisis rapid response team that we work directly with on those calls as well. But having that identification of a mental health related call is very, has been a game changer for us in our community. And we've really found that to be effective.
And I know, Jennifer, you shared in a previous Crisis Jam, Crisis Talk article, right? Some of the takeaways for other centers in 911 PSAPs looking to coordinate with each other. Do you want to share kind of top line for folks who may have missed that?
Yeah, and please check out that article. It's so well done. I was really impressed with the team that wrote that. And also our center has consulted with probably over 80 different municipalities and communities about this program. We are open to sharing any information that we have with anybody. I'll add my email address. You know, our ultimate end game is to try to do anything that we can to help reduce the number of law enforcement interactions for people with mental health needs. And so we've seen that, you know, significantly. We have an over 50% diversion rate for anybody that talks to one of our behavioral health clinicians to avoid law enforcement interaction, which we're really proud of, and also, you know, saves almost $1.5 million a year to our city. So, you know, money when you want to talk about how do we fund these things moving forward. So, you know, I believe that not all of those models are going to be able to, as we talk about scalability, I'm really liking, you know, talking with some of, you know, the folks at D.D. Hirsch in LA and St. Louis, you know, some of the other cities who are looking at that transition between how to get a call out of the dispatch center into the crisis center. A city like ours, it makes perfect sense. You know, we're talking to thousands and thousands of people a day. So the scalability to have people inside of the call center makes sense. But in some of the smaller communities, it doesn't. And so, but we believe that we have enough experience and background and knowledge and protocols working with our emergency call division, our mental health division, our police department, and our behavioral health authority to, you know, share our findings and support people as they're trying to build these, as we figure out what we're going to do next with the 988, 911, law enforcement. There's a lot going on. Kelly,
Definitely a lot to definitely a lot to unpack there. I do want to make sure I get a question to Tiffany around that came through the chat around racial equity in these processes. Have you seen that in either your pilot or any of the other reports that were recently released?
You know, we did not see a lot of that. And that's why it's going to be such a main focus for us moving forward, is really wanting to, as part of our research agenda, really wanting to dig down into racial equity as it relates to different types of interventions. Are there interventions that affect communities of color differently, that are responding to communities of color in a more effective and efficient, equitable way? And so we did not see a lot of that racial equity coming through the research that we found when we first started this project. And we definitely feel as though that is going to be a place for Pew to really kind of focus in on really trying to pull some of that information out. And we hope to use those pilot states that we're working with to be able to really identify what the data is saying around racial equity as it relates to crisis behavioral health emergencies.
Great. And there's another question in the chat that Tiffany or Jennifer, if you all want to take a crack at it, but I think this actually may be more geared towards Samsa. So I'll bring in any of the Samsa folks as well. And that's a question around caller frustration when additional services may not be available in their local area. So I think you mentioned just 2 out of 5 have connections to mobile crisis teams. So was there any information in your report related to how dispatchers or others may handle that caller frustration?
I mean, I think a lot of the frustration also is coming from the call taker and the call dispatcher, that they don't have anything other than law enforcement to rely on in responding to these behavioral health emergencies. I definitely know that a lot of them were really interested in how can they get behavioral health clinicians into their call centers, because the research does show that those behavioral health clinicians are able to de-escalate those calls where there does not have to be a response that comes out to that person's home or to that person's location. And so it definitely shows that having more access at the upstream with the behavioral health clinicians really does de-escalate those calls and resolve them for the most part. But we also, in talking with the respondents, it's all due to budgets. And that's one of the reasons why we wanted to make this really key focus on the reporting of data. We all know that when you're trying to talk to decision makers and budget makers, that unless you have the data to properly respond or show the need, that they're not going to respond to anecdotal stories. They're gonna want to see data that responds to that. And if you don't have that data, you don't have a data to show what the volume of calls looks like, the frustration from the callers, you don't have anything to really back up what you're saying, it's very hard to ask for more resources like behavioral health clinicians or a telehealth behavioral health clinicians to be available in your 911 call centers. And so that's why we really wanted to impress upon 911 call centers the importance of not only collecting the data, but reporting it outside of the walls of your organization.
Yeah, Jennifer, anything to add there, particularly from your perspective of a Lifeline Crisis Center, right, which is able to de-escalate the majority of calls without needing additional interventions like a mobile crisis team. So anything you would like to add there?
No, I totally agree. And also the data piece is so key, right? You know, the more different kind of data warehouses and databases that we're running from all the different entities absolutely is one of the biggest struggles when we're looking at data prevention. You know, it's really easy for us in our center to talk about what we call primary diversions, which are those 100% no law enforcement or EMS went out because our person talked to this, you know, caller. The more challenging data are what we call these secondary diversions, which is, you know, we have some tangential data that says, you know, if somebody received an intervention from one of our behavioral health people at 911 and law enforcement still had to make the scene because of all of the protocols that we have in place with them, that law enforcement is still on the scene for up to 50% less time. So that intervention that was already done, the de-escalation that was already done using those awesome crisis line skills is still really impactful. But that data lives in the 911 data place, right? Like not in the crisis center data place. So being able to pull all of that together to give a really robust view of the impact is significant. And then tertiary data is, can we change behavior? You know, are we really able to take people that are calling 911 for non-imminent risk behavioral health concerns and, you know, safety plan with them to the point where in the future they call through the local crisis center or Lifeline /988. And so those are some pieces that we're still uncovering.
Well, I just want to thank you, Jennifer, for being part of the roundtable. Thank you, Tiffany, for this insightful presentation. We look forward to more information coming out on those pilots and the February release of another study. So, you know, we just want to ensure, I think there are some common themes here, right, around funding for both 911 and 988 and training and availability of the service array. So, you know, I think this is going to be a hot topic to come, and I'm sure we'll have you both back for future presentations. So we move forward, and there's been some great discussion in the chat as well. I know people are sharing their information and contact emails and links. So make sure that you are checking that because there's some really great discussion going on there. I'm going to pass it over to Stephanie Hepburn, who is the Crisis Talk editor, and she's going to talk about the interview this week with Dr. Maddie Gould. Stephanie?
Hi, Laura. Thank you. Yeah, so I spoke with Dr. Madeline Gould, and she's evaluated the Lifeline over the past 2 decades. She's studied whether the crisis intervention service significantly decreases suicide risk, despair, and hopelessness, which it does. And what we really talked about for the bulk of the article was, with 988 on the horizon, what's the role? What kind of feedback loop can transpire? And she talked about automation and the role that can play, especially as the Lifeline is going to grow potentially exponentially. She talked about how surveys at the end, especially when they're automated, can create this vital feedback loop. Dr. Gould, if you're on the line, if you could talk a little bit about that.
Hi, thanks very much, Stephanie. I so enjoyed talking with you when you interviewed me. You know, as Tiffany and Jennifer just emphasized, data is critically important to inform the quality of services that are provided. And when I spoke on the Crisis Jam a few months ago, I didn't have the chance to go into detail about the different measures that we've developed for the, numerous evaluation projects that we've conducted. And so when you and I spoke, Stephanie, you gave me the opportunity to really describe some of the assessments that we developed, and that, we developed them for the evaluation. But we also want to empower crisis centers and the Lifeline to use these measures on their own. So they have to be low burden, assessments. Some centers are already using some of our assessments, but we're hoping that in the future that more crisis centers and Lifeline on their own will be able to use this, as you described, this automation, intervention feedback loop. So I'll be very concrete when I describe at least one assessment that we are very enthusiastic about having applied as a quality improvement measure, or quality improvement metric. And that's a post-call survey that we have interviewed thousands and thousands of callers, and we've assessed, actually thousands of chatters as well. But what we do would be too labor intensive to be feasible on an ongoing basis. And as 988 is right around the corner, we need easily available, easily implementable measures. And this post-call survey that we've been piloting in our current evaluation comes on automatically at the end of the, in this case, call, because we've only done it with callers for the current evaluation. And it's brief, it's quick, it's easy. The callers have given us an enormous amount of information, and this survey can provide information in the future on the not only the caller's perceptions of quality and engagement with the person who intervened during their crisis, but can also get information that's currently unknown, which includes the information about the caller's racial background, ethnic background, gender, age, and that, when we're talking about racial equity, well, one of the things that's needed is a description of callers. In this case, it will be to 988. And a post-call survey can provide that information in a low burden way. So that's just one snapshot about one assessment. But I'm really glad, Stephanie, that in the interview, you gave me the opportunity to really describe it in detail, so that going forward, that this automated feedback loop can be available to the expanding crisis system that will really be critically important to address the mental health needs of our population, and particularly to enhance racial equity.
Thank
Yeah.
you so
Dr.
much for
Gould,
taking the time to chat with me.
Oh, thank you. Thanks for inviting me today.
Sorry about that, Steph. Dr. Gould, I think this is so important, as Tiffany just reiterated the importance of having that data. So we are going to make sure that folks know how to read your article to get to that detailed information, and that is on talk.crisisnow.com. It's a really fantastic article. Dr. Gould has been producing the evaluations for the Lifeline and showing how effective the Lifeline is in de-escalating distress and keeping people safe. So thank you so much for that. And of course, these slides and this presentation is available on talk.crisisnow.com following the Crisis Jam. So we're going to keep moving forward and go to our next segment here. On the next slide, please. All right, and so we mentioned last week that the crisis hot seat questions were going to get a little tougher, and I will fully acknowledge that I missed this question. So in this week's hot seat, we have Aisha Delaney-Runzi from sorry, I have a little razzle dazzle with an airplane going overhead, from the Council of State Government's Justice Department. So Aisha, so Connections Health Solutions from Arizona pioneered crisis receiving no wrong door beginning in 2009. You know, based on Margie's previous presentation to the Crisis Jam, crisis services are fully integrated at the peer level, and they see about 15% of adults present with substance use disorder as their primary diagnosis. How many have a total, how many individuals have a total diagnosis, either primary or secondary, of SUD and or a positive toxicology? So kind of take that 15% and add it to the other folks where substance use disorder may be secondary.
I do feel like these questions are getting harder. So I feel like I wish I'd gone a couple of weeks ago. And do I still get like the audience feedback? I know Margie's in the also on the call, so I want to do right by her.
Yes, we've got a poll, so you can ask the audience if you want to go ahead, audience, and select what you think the total percentage is. So 15% would be a part of whatever answer you choose. Let's just keep this open. And of course, you could phone a friend, but I'm not going to allow you to phone Margie.
Okay, that's fair, Laura. That's fair.
So let's see the results. Interesting. All right. I don't know how helpful this will be. It's pretty evenly spread between 45%, 55%, and 65%.
Well, I do. Yes, I think the wisdom of the crowd is not quite as helpful as I would hope it would be, but I'm going to go with, I'm going to lean on my instincts to go with a little higher than I might have guessed. And I'm just going to go with the 65% and see where we land.
Okay. Final answer?
Final answer.
All right, let's get that answer up there. You are right. Yes. So if we take a look at that, it is 15% of folks with a SUD as a primary diagnosis, and then about 50% have a secondary or positive toxicology. So I admit that I got this wrong. I thought this was 45, but Aisha, you have come in with the correct answer. So we see methamphetamine and alcohol account for 75% of the SUD diagnoses, in crisis receiving services benefit from having monitored detox, medication assisted treatment, and other counseling. I think Paul mentioned that even though this question is specifically around what they saw in Arizona, but this kind of tracks with other states. I think that would be interesting to have that national data. But thank you so much, Aisha. This was a tough question and you survived the hot seat, so congrats.
Thanks, Laura.
All right, let's keep moving. I'm going to turn it over to John Palmieri to give us a Samsa update.
Thanks, Laura. And I know we're a little bit short on time, so I'm going to try to be quick, and then I'll pass it off to other folks on the 988 team to see if they have any updates. But really appreciate the discussion thus far today. I mean, I think elements that have been tracking in this conversation about building out the crisis system, sustainable funding, data, developing protocols with 911. I mean, these are all really critical areas that are worthy of their own kind of hour and beyond for discussion. But certainly areas that Samsa has been very focused in on as well, in terms of its engagements, its funding, and in the technical assistance and guidance that we're looking to develop for the field. So just very quickly, been very involved in briefings, both with the Assistant Secretary and with our HHS Secretary, who are very engaged in what's happening in 988 in the crisis space. Also a lot of interest from the White House as well. And we're really using that opportunity to raise visibility to current challenges in the system and obviously opportunities that we see to support that transformation. Also doing a lot of work with engaging states and state leadership around the federal state partnership and 988 crisis services, and we'll continue to do that moving forward, both in terms of funding and again, in terms of technical assistance and guidance in terms of implementing services. We did have a very successful financing meeting with CMS and other partners on this call last week, really addressing sustainable options for funding across the crisis continuum. Some really excellent presentations from many panelists who are sitting on this call right now. So again, thank you for that. And then also providing some additional funding through our transformation transfer initiative through a partnership with NASHBID, which I think Brian might have mentioned last week, which provides some additional awards to states and territories to support crisis build out. We're actively involved in our co-sponsorship activities with partners to support an understanding of readiness and the criteria for readiness and across core audiences who are critical to 988 implementation, and then really leveraging some of our partnerships within government through one example of that being the Behavioral Health Coordinating Council through HHS, which has work groups focused in on data and workforce, among others. And again, thinking about longer term planning around data and evaluation of the system and building out and scaling a workforce. So in the interest of time, I'm going to stop there and just see if anybody else from the 988 team, James, Richard, Kate, anybody else wants to add anything.
This is Richard. I'll just add that the feature presentation today was particularly timely. We're focusing a lot of attention on the issue of 988, 911 collaboration. It's a critical issue moving forward. And so, we want to learn as much as we can and make sure that we are able to work with a wide array of partners as we get closer to July 22. Of course, this is an important issue right now, and it will be an important issue after July 22. But we think that 988 being such a similar number to 911 will just increase the importance of this collaboration being well coordinated and as seamless as possible.
Great, thank you, John and Richard. Again, really appreciate your leadership here. So I'm going to turn it over to Brian Hepburn from Nashville.
Thank you, Laura, and another nice job on your part. Thank you very much. I wanted to just piggyback real quickly on what John mentioned about the meeting last week. Samsa pulled together a 3-day meeting, a half day each day that he mentioned, and it was leveraging Samsa and Medicaid resources to establish a comprehensive and integrated crisis system of care. It basically had Samsa and CMS bringing together the Medicaid authorities, the mental health authorities, and the substance use authorities from each state. And I wanted to highlight a presentation from Connecticut on children and youth. It was an excellent presentation. We're hoping to get that presentation for a future JAM meeting. And if you have an opportunity, take a look at what Connecticut is doing in terms of children and youth crisis services. And with that, I'll go to the next slide. please. Next slide. Thank you. And with this, I'd like to bring in Deb Pines. Deb?
Yeah, hi, everybody. It's great to be here. I want to just congratulate Aisha for getting that question right and my friend Tiffany for doing such a great presentation, really exciting. And thank you, Brian. I am working with NASHBID. I have the privilege of doing the work again to try and pull together the papers that have been utilized as technical assistance for state behavioral health leaders and others. You can see we have a series that we started in 2017, the Beyond Bed series, which really spoke about the vital importance of a psychiatric continuum of care. And obviously crisis services is one of the key components of that. After the Samsa toolkit came the crisis services, meeting needs, saving lives, and then Ready to Respond was last year's initiative. This year, we're going to be continuing in the technical assistance papers with the theme of crisis response, 988, trauma-informed services. We're going to have special papers that are going to focus on self-directed care, around building from beyond crisis to access points, CCBHCs and urgent care centers. We're going to be looking also at the role of law enforcement and EMTALA related to crisis services. So stay tuned. There's going to be a series of 10 papers, and I'm excited to be working in partnership with NASHBID to help with those.
Thank you, Deb. Back to you, Laura.
Thank you, Brian. Thanks, Deb. Lots of great work always coming out of your organization. So very glad to be partners on that. At this point, I'm going to turn it over to Sarah Corcoran for an update on federal activity.
Thank you, Laura. I'll be pretty quick. No real substantive updates on the first or second row since last week. It looks like we might be coming closer to an agreement on FY22 omnibus spending, but still a little bit of ways to go on that. So hopefully we'll have more in the coming weeks on that. And if Build Back Better is moving again. But on the third row, it looks like the Senate Finance Kids Mental Health hearing is being rescheduled from the 26th of this month. Since the Senate is in session this week instead of being on recess, it looks like they're flipping their schedule. So we'll keep an eye out for the future date of the hearing with the Surgeon General on kids' mental health, and then a future hearing later in February on a second panel on the same topic. So we'll keep you posted as we learn new dates for the hearing.
Great. Thank you, Sarah. Really appreciate you keeping your eye out on that for us. There's a lot going on. And sometimes it doesn't work out like Build Back Better, but hopefully we will see action and appreciate you watching. So let's move forward. And I'm going to turn it over to Steph Pasternak from NAMI and Taylor Kleffel from AFSP for any state level updates.
Thanks, Laura. I will be extremely quick. Some encouraging news out of New York. Governor Hochul released her proposed budget, and for 988, there's some good news. 35 million is proposed for fiscal years 22 and 23, and that number would grow to 60 million for fiscal years 23 and 24. And this is on top of what the state has already allocated in federal funding for 988. Also just wanted to flag a couple new states that you might see on the map here. There is a new bill in Mississippi, House Bill 732 creates a study commission on 988 that'll perform a comprehensive study of the state's behavioral health crisis response system and develop funding recommendations for 988 call centers and crisis services. And also there are new bills in Maryland, House Bill 293 and Senate Bill 241. This kind of formally establishes 988 as Maryland's behavioral health crisis hotline and establishes the 988 trust fund. So that is not the 988 fee, but sort of the sequestered, non-reverting 988 account to sort of store all 988 related revenue. And I'll throw it over to Taylor if she has any additional state updates. Thanks.
Well, thanks, Steph. I think you did such a good job covering that. I'm going to move us forward. And if you are looking for specific information of what's going on in your state, legislatively or with your mental health agency planning wise, I do recommend that you reach out to your mental health agency, as well as the link that Steph shared. It has a list of bills pending, but there's a lot of activity going on that you won't necessarily see as an introduced bill just yet. So we also have the state cards. I'm going to go through them very quickly, just outlining states that have articulated a specified fee in 4988 in their legislation. So we're going to move forward because we've got about 1 minute left. And I think we are actually at time. So if we just go to the last slide, you will see what's coming forward in the jam. I apologize, Paul, that we did not get to you and did not get to review the word cloud, but we will pick that up next week when we have Patrick Kennedy discussing Medicare parity and crisis. So thank you all so much. Really appreciate you spending your afternoon and morning with us. Hopefully you learned something. I know I did, and we will see you next Wednesday.